I welcome you all to yet another academic session of Gynae Academic Club. The whole idea about Gynae Academic Club was like it germinated with the basic idea of talking science and discussing academics. Most of the times it happens that we all mingle so many things along with it, which was not the motto of this group, and that was the main aim. We have been till now. It's a very small group and group by invites only. So still the flavor is maintained, I would say, as far as academics is concerned. And we have been very successful as far as the scientific topics which were chosen up till now were concerned. We've discussed amply about many of the medical disorders like thyroid disorders in pregnancy, diabetes in pregnancy, valvular heart diseases in pregnancy, and of course, and all the 3 trimesters discussion on blood disorders as well as sonography pulse into this gynec academic forum. We also have discussed a few things on the public health related stuff, the healthcare workers, and on times about PPH as well. Today, I welcome the esteemed speakers who would enlighten us as far as the today's topic of tips and tricks for obstetrics is concerned, and it all would be in all a very enriching session. I welcome you all as far as the Gynae Academic Club today's session is concerned. Thank you. Over to Fatima.
Thank you so much, sir. I heartily welcome our beloved Dr. Preeti Kumar, ma'am. She is the founder of Gynae Academic Club. She is chairperson, Safe Motherhood Committee, co-chair Maternal and Perinatal Committee, SAFOG, vice president, Lucknow Obs and Gynae Society. She is the key person behind this academic evening. I welcome you, ma'am, and I request you to kindly shower your blessings on us.
Thank you, Fatima. A happy Republic Day to all of you. First and foremost, we humbly bow our head in front of Dr. Chandravati ma'am and Dr. Manju Shukla ma'am, because this club is being run under their guidance, and Dr. Chandravati madam is the chairperson and secretary is Dr. Manju Shukla ma'am. And we are really thankful to them for all their guidance and support for running this club. Special and very special gratitude to Dr. Atul Ganatra sir and Dr. Sheila Mane and Dr. Poonam Shivkumar ma'am for joining today. And I must congratulate Dr. Fatima and Dr. Tanushri, because it's an open forum to encourage academics, and it is an open forum to impart knowledge to the young ones and youngster, especially young OBGYNs, and it's basically a learning platform. So I really want to congratulate these two young Dr. Tanushri and Dr. Fatima for taking all the initiative for organizing this today's event. So thank you so much once again, and those who have joined today, thank you for sparing so much time on this day. And I know it's a holiday and everybody wants to enjoy with the family, but thank you so much. Academics has to go on, and we are really honored to have such learned faculty today on board. So we will be looking for the question and answers also at the end of the session. Thank you so much. Over to Fatima.
Thank you so much, ma'am, for your kind words. Before we move on to our academic session, let us come together and invoke the blessings of Ma Saraswati. Let us all raise our hands in reverence to light the lamp of knowledge, the light of hope and happiness, the light of good health for all.
Fatima, before you invite chairperson, I would really like to thank, I'm really sorry I missed the name of Dr. Uma Singh madam and Fagun, of course. And thank you so much for joining today, because Dr. Fagun, you had been a great guiding force for the academic sessions. And Dr. Uma Singh madam, thank you so much for joining. Yeah, Fatima, you can carry on.
Thank you, ma'am. Let us now move on to our scientific program. Our first session is a talk by Dr. Sheila Mane ma'am on carbetocin, the most awaited uterotonic. It gives me immense pleasure to invite our teacher of teachers, respected Dr. Chandravati ma'am, who needs no introduction. Her presence and guidance boost so much of confidence in our students. She is an epitome of knowledge, kindness, and compassion, truly redefining the value of being a teacher. I request ma'am to kindly introduce our guest speaker, Dr. Sheila Mane ma'am. Over to you, ma'am, please.
Thank you, Fatima. It's a pleasure to be here today, and especially on a very special day, on a very, very special topic to discuss today, because this is calamities, a very important cause of maternal death that we want to avoid. And to discuss this on such a very important day, I think it itself says the value of this. And to welcome Sheila, she's like, I know, family part from Lucknow, because we have been with Sheila so many times, and every time she had been here to Lucknow so many times, and I feel she's just nearby somewhere. So welcome, Sheila, and I don't think you need introduction, because everybody knows you around, but just a formality. Dr. Sheila is a consultant at Anugrah Nursing Home. We all know she had been a governing council member, ICOG 2021. She had organized a wonderful conference at Bangalore 2019. Now President Bangalore Menopause Society 2022. She had been a chairperson, Safe Motherhood Committee, brought this committee to such a high level that Preeti had to work so hard to, go beyond that. And she had been a past president of Bangalore Society, 2005-6. Secretary Indian Menopause Society, Bangalore, 2012 and 14. Sheila, you have chosen a very wonderful topic, carbetocin, the most awaited uterotonic. I think each one of us are now convinced that this is a magic substance, what we have got it now. And I too have an experience of using it in more than 150 women so far. And I'm really concepting where I had to use something else along with it.
Hello. Madam, connection is...
Madam's connection is poor actually.
Can I start the share?
Just a minute, ma'am. Yeah, you can start.
Thank you, Madam Chandravati, for those wonderful words. And as you are teacher of the teachers, I think it's my privilege to be there in this meeting. And as you said, yes, definitely, I think we are a family, and everyone at Lucknow is very close to my heart too. And I still have the good memories of Lucknow AICOG 2020. And now I will start sharing my screen. Is it seen? Can you see my screen?
Yes, make it full screen, Sheila ji.
Yeah, correct. Thank you. So mainly I'm going to concentrate on the oxytocics, yes, and then I will highlight about the carbetocin. It's very nice to know that none other than but Madam Chandravati has already has such a huge experience about it, and that's really nice to know. So coming to postpartum hemorrhage, I think whenever first is the oxytocics, that is the medical therapy, which is important. And before I start, once again, I would like to thank the Gynec Forum, Dr. Tanushri and Dr. Preeti and everyone for inviting me. And really nice to give this talk on our Republic Day. So coming to the point, the medical therapy, the treatment of patients with PPH has two major components. That is resuscitation and management of obstetric hemorrhage and possibly of a hypovolemic shock, and identification and management of the underlying causes of the hemorrhage. Okay, so we'll have to discuss this separately, but here mainly we will concentrate on the initial assessment and the oxytocin. Now, initial assessment should be the risk factor and the events leading to the diagnosis of PPH, suggest an underlying etiology, because it's very important when the patient is bleeding, whether it is traumatic PPH or whether it is atonic PPH. So we will have to find out that. Most cases are caused by uterine atony, and there is a need to be systematic argues for a planned and a stepwise approach to assessment and management. Now, status of the patient, severity of the bleeding, response to initial management steps determine if and when the protocol for massive obstetric hemorrhage is instituted. Now, coming to uterine atony, oxytocin should be the first drug of choice for both prophylaxis and treatment. And oxytocin was only available with us so far. So we have to assess the uterine size and tone by massaging the uterus, which serves to express any clots that are there in the uterus or vagina. Boggy and not well contracted, you have to commence vigorous massage and therapeutic oxytocin. Therapeutic will be 20 units in 1 liter of normal saline intravenously, run as fast as possible, or again we can repeat the 10 units intra, or we can give even myometrial with a spinal needle if no immediate intravenous access is available. Yes, easier in a thin patient. Emptying the bladder may aid, and if the uterus still remains atonic, we will have to commence bimanual massage. So the compression expels the clots and decreases bleeding. Massaging the uterus between the hands aid in promoting and sustaining contraction, and bimanual massage results in a decrease in bleeding and uterus in bleeding from the uterus, and uterus remains contracted. Intramuscular carboprost is another alternative which we are using so far, which is second line agent and the dose is 250 microgram intramuscularly or intramyometrically. Asthma is a relative contraindication. We know that carboprost has shown to be 80 to 90% effective in cases refractory to oxytocin and ergonovine, but that is for the therapeutic management. Now, misoprostol is again a valuable agent in the treatment of PPH, and recent trials are examining whether the more rapid onset of sublingual or buccal misoprostol will improve its efficacy in the setting of acute PPH, but still remains a third line agent in the management of PPH. The low cost of the drugs, so it is used in the developing world. And investigational, we used to say so far, but now we have carbetocin with us. Now, the medical management of atonic PPH, the another drug which is there in our kitty now is the tranexamic acid. Now, the bleeding, if it proves unresponsive to uterotonics, consideration may be given to tranexamic acid, which is a synthetic derivative of lysine with antifibrinolytic properties, or recombinant activated factor 7. Now, factor 7 is rarely used only in tertiary care centers. A 2010 Cochrane review of tranexamic acid reported decreased blood loss after vaginal as well as cesarean birth, but called for further investigation about its efficacy and safety. But now, after the women's trial is out, we know that the WHO has recommended tranexamic acid where oxytocin and prostaglandins fail to control atonic PPH, and it should be used as early as possible. If it is used within 3 hours, the mortality can be reduced by 30% if it is only due to PPH. And COG reports that fibrinolytic inhibitors seldom have a place in PPH management. That is there, but now we know after women's trial, we do use it. Aortic compression, I mean, these are all the methods which we'll be doing along with the medical management. And also we will have to practice all these methods so that the bleeding is under control, because the uterotonics will take time to act. So if bleeding persists even after administration of uterotonics, consider these potentially life-saving bimanual compression of uterus, aortic compression, or we can use hydrostatic intrauterine balloon tamponade, or use of an anti-shock garment for the treatment of shock or transfer to another level of care or while waiting for a cesarean. I know Dr. Preeti is here, Safe Motherhood Committee Chairperson, Jeevandhara project is going on, and really happy to see that the way every health worker is being trained to practice this, that is the UBT balloon as well as the use of anti-shock garment and the PPH bundle. Yes, laparotomy if everything fails to apply compression suture using either B-Lynch or modified B-Lynch. Okay. If we are doing the aortic compression, we will have to explain it to the patient and the family to do this. Ensure clean hands and use sterile gloves. Place one hand in the vagina, and that this is about bimanual compression. Anyway, I will not go into the details. Then coming to the aortic compression, again, the steps I will like to tell. Explain the procedure to the woman if she is conscious and reassure her. Stand on right side. Place the left fist just above and to the left of the woman's umbilicus because the abdominal aorta passes slightly to the left of the midline. Lean over the woman so that your weight increases the pressure on the aorta, and you should be able to feel the aorta against your knuckles. Do not use your arm muscles. That is very tiring. Before exerting compression, feel the femoral artery for a pulse using the index and the third fingers of the right hand. And once the aorta and the femoral pulse have been identified, slowly lean over the woman, increase the pressure over the aorta to seal it off to confirm proper sealing and check the femoral pulse. There must be no palpable pulse in the femoral artery if the compression is effective. And should the pulse become palpable, adjust the left fist and the pressure until the pulse is gone again. The finger should be kept on the femoral artery as long as the aorta is compressed to make sure that the compression is efficient at all times. So you will need definitely the assistant who is telling you, yes, the femoral is not fed. Basically, doing all these methods is just to control bleeding, Yes, staying prepared is always the key. So ensure that obstetric care providers are adequately prepared for handling hemorrhagic emergencies. Should be accomplished through high quality medical, nursing and midwifery education with ample opportunities to practice and managing rare events by verifying that all the tools and the materials required for PPH interventions are readily available. It is also important that standardized protocols and guidelines be adopted and monitored to ensure that facility level practices are evidence-based. And these are the things which we know that we should be kept ready. We should have the Mama Natale when we are trying to do the drills and trying to explain to the people, and also the cards and boxes to be kept ready. Yes, postpartum hemorrhages predict, prepare and handle. Atonic PPH more common because the uterine blood flow at term is 700 to 800 ml per minute. The uterus can simply pour and lead to death. Even smaller blood loss matters in women with low BMI, anemia, and preeclampsia, which is a common scenario in our country. So we should be ready. We have to practice active management of third stage of labor in every woman, and we should know the hemoglobin and blood group of every woman. So once the PPH is diagnosed, the golden hour starts. We can even have code H because H is for hemorrhage. And whatever we are doing should happen at once. That is, shout for help, resuscitation with IV fluids and oxygen, arrest the bleeding, which we already learned, and communication, which is equally important with staff, with patient, family, and identifying the cause of bleeding. So ABC, 2 large IV access cannulas, gray or green, get more help, and oxygen by face mask, and infuse crystallites, either normal saline or linger lactate 3 times in a volume to the blood loss. Immediately reserve and gets 2 units of PRBCs. Continue massage and continue giving other oxytocics. See, if you look at the gray color cannula, why we have to have a big bore cannula? Because you can transfuse the fluid 180 ml per minute. Even abroad, they recommend even 14, but our women are thin and there might be double puncture. Even sometimes gray also doesn't work, but one must have at least a green. So you have to start the medication. Oxytocin 10 units IM or 5 units IV bolus slowly can be given over a period of 2 to 3 minutes, or at 20 units in 500 ml of ringer lactate, can give carboprost intramuscularly, even methyl ergometrin 0.2 milligram, 0.2 milligram either IV or IM, and misoprostol third line 800 microgram rectally. You have to identify the cause of bleeding, evaluate atony, lacerations, hematoma, inversion of uterus, retained tissue, accreta or coagulopathy. That is, you will have to diagnose what is the cause, which T is the cause. Parameters to be assessed, all the vital parameters, okay? And if the blood pressure is less than 80, worsening tachycardia and tachypnea will be their altered mental status, which indicates the PPH of more than 1500 ml, which is a third, I think that will be the class 3 hemorrhage. Rule of 30, fall of systolic blood pressure by 30 millimeters of mercury, pulse rate increased by 30 beats. urine output less than 30, hematocrit less than 30, which amounts to blood loss of 30%, and shock index, which is a very simple clinical parameter, pulse rate divided by systolic blood pressure. If more than 1, it indicates that the patient is in shock. So this is the chart which I have for the oxytocin. Oxytocin, we know, has to be stored in a refrigerator because it is not heat stable. So that is the advantage now with which we are going to talk about carbetocin, the advantages of carbetocin over oxytocin. And it is being used regularly now for active management of third stage of labor. And we know it is very safe. Okay, onset of action is 2 to 3 minutes, last up to 15 to 20 minutes. Then misoprostol, again, 600 microgram as a prophylactic, but 800 for the therapeutic dose. It can be stored at room temperature. Argonavin, again, needs refrigerator storage. Okay. But, after you have given, you cannot repeat the second dose up to 2 to 4 hours. Carboprost can be given every 15 minutes as a therapeutic drug. You can go up to 2 milligram. And we know the contraindications, bronchial asthma, side effects are, again, vomiting, diarrhea. Again, the storage is very important. So unless and until the cold chain is maintained, these drugs are going to lose their potency. And tranexamic acid, just now I told about that, 1 gram in 10 ml IV at 1 ml per minute, or it can be added to even 100 ml normal saline solution can be given. Okay, and should be used cautiously with thrombotic events or family history of thrombosis. Again, it can be stored at room temperature of 15 to 30 degrees centigrade. Communication is very important with patient, with family, with staff, with seniors, and with support system. We should check whether the patient requires blood depending on her general condition. And other measures, depending on the condition, everything should happen within the golden hour. In labor room, sutures, tamponade, packing, or NSG, and in the OT, depending on the situation, which Dr. Ganatra will tell. We can have these type of charts in our labor room where we have given the steps. The step 1, that is the general management. Step 2 is the directed therapy, depending on the cause, that is which T is causing that, and the oxytocin, which we discussed. Now, coming to postpartum hemorrhage scenario in India, is the leading cause. Prevalence is 38%, and PPH accounts for up to 56% of maternal deaths in India. Now, is definition, all of us, we know vaginal delivery more than 500 ml, cesarean more than 1000 ml, or any amount of blood loss within 24 hours after birth, evidenced by a rise in pulse rate and fall in blood pressure. Okay. So causes of PPH, 4 T's, atonic uterus is the commonest. Okay. And which is accounts for 70% of the cases. Now the risk factors, again, prolonged labor, grand multipara, whether the labor is augmented or could be a precipitate labor, if there is a previous history of PPH, over-distended uterus, operative delivery, and chorioamnionitis. Now WHO recommends active management of third stage of labor for prevention of postpartum hemorrhage. Yes, we have to also do all this simultaneously if we have diagnosed postpartum hemorrhage. So prophylactic administration of uterine agents is defined as the most important component of the active management of third stage of labor. Now, postpartum hemorrhage after cesarean delivery has become an epidemic in India, and it records 300% jump in last decade. Why? All of us, we know there is a rise in the incidence of cesarean section, and the incidence of PPH in cesarean delivery is almost 6.75% than vaginal deliveries, which is 2 to 4%. So definitely we are facing more and more cases of PPH after cesarean deliveries, okay, as compared to vaginal, and 36% of cesarean deliveries are complicated by postpartum hemorrhage. And therefore, it's a common practice to give a uterotonic drug following delivery of the neonate during cesarean section and for every delivery, in fact. Now, the international consensus statement on the use of uterotonic agents, all of us we know, like either oxytocin or carbetocin, are recommended for routine administration immediately after delivery of the fetus, even delivery or cesarean section. So they are very essential, okay, to diminish the risk of PPH and improve maternal safety. If you look at uterotonics drugs, yes, posterior pituitary hormone and analogs are oxytocin and carbetocin. Ergot alkaloids are ergometrin and methylargonovin. Ergometrin and prostaglandins are PGE2, misoprostol, and carboprost. They are first line, that is pituitary extracts, and all other are second line drugs. So oxytocin considered as a gold standard treatment for the prevention of postpartum hemorrhage, but oxytocin is short acting, half-life is 4 to 10 minutes, duration of action is 15 to 20 minutes, and it must be administered as a, suppose if we want to continue, as a continuous IV infusion to attain sustained uterine activity throughout the surgical procedure and immediate postpartum period. And another thing is it causes receptor desensitization. Now, so many times oxytocin is used for either induction of labor or for augmentation of labor that may desensitize the oxytocin receptors, thereby impairing oxytocin's post-delivery effect on uterine contractility. Now, also there is a variation in dosages. Various international bodies and trials have used and recommended different dosages of oxytocin. So there is no consistency in dosage regimen, which results in error in administration. And the Institute for Safe Medical Practices added oxytocin to their list of high alert medication. I mean, it has to be given properly. If one person is somebody is using it IV, it cannot be given very fast because it can really cause some complication. So need of an hour is we need a longer acting single dose of administration, no variation in dose regimens, devoid of repeated administrations, ease of one-time administration, superior efficacy or similar efficacy as that of oxytocin, devoid of receptor desensitization, and superior side effect profile over oxytocin. So that is carbetocin. Now, what is carbetocin? Carbetocin is a synthetic analog of human oxytocin with some structural modifications as shown below. So the first one is carbetocin and the second is oxytocin. So where there are red circles, we can see that that is the difference between the oxytocin and carbetocin. These structural modifications increase the half-life of carbetocin, thereby prolonging its pharmacological effects. Now, WHO, it has been added to the WHO essential medicines list of uterotonics for the prevention of excessive bleeding after childbirth. And WHO's list, if we look at this recommendation of 2018, you will find that carbetocin is been mentioned in the WHO recommendations for uterotonics for the prevention of postpartum hemorrhage. So oxytocin is recommended first, and the next is the carbetocin, and the use of an effective uterotonic for the prevention of PPH during the third stage of labor is recommended for all births to effectively prevent PPH, and one of the following uterotonics should be used. So first is oxytocin, then is carbetocin, then misoprostol, then ergometrin, and then the, even we can use the combinations. So carbetocin is recommended by WHO as an effective uterotonic in its 2018 guidelines. Carboprost is not recommended by WHO for the prevention. Now, carbetocin versus oxytocin. Half-life for carbetocin is 10 folds higher than oxytocin. Okay, it is 40 minutes. Duration of action of carbetocin is longer than IV and IM oxytocin. And a single IV bolus injection of carbetocin was at least as effective as 16 hours of continuous oxytocin infusion. Carbetocin, no need to repeat administration, no dose variation. Single dose of carbetocin is found to be effective in controlling PPH, unlike oxytocin, and is superior over oxytocin with respect to its pharmacokinetic parameters and single dose administration. How does it work? It has been studied throughout the world, Europe, America, Asia, Africa, and it is used for the management of third stage of labor during vaginal delivery as well as for cesarean section. Okay. Now, the management of third stage of labor during vaginal delivery, this was the study, IV carbetocin versus intravenous oxytocin for preventing atonic PPH after normal vaginal delivery in high-risk singleton pregnancies, a triple blind randomized control trial. And there were 174 women with high-risk singleton pregnancy. Carbetocin 100 microgram slow IV over a 1 minute, and oxytocin 5 units slow IV over a 1 minute was given. Outcome measures were incidence of atonic PPH, postpartum blood loss, additional uterotonics, incidence of postpartum anemia. And incidence of atonic PPH, they found after giving that, it was 0% with carbetocin and oxytocin 6.3%. Postpartum blood loss was again lesser with carbetocin compared to oxytocin. Need of additional uterotonic drugs also was only 9.1% with carbetocin, 27 with oxytocin. Anemia also was definitely, as the blood loss was less, was only 9%, and here 18% with oxytocin. So intravenous carbetocin is more effective than IV oxytocin for the prevention of atonic PPH among singleton pregnancies with at least one risk factor for postpartum hemorrhage. Then another article, efficacy and safety of carbetocin in comparison to oxytocin in the management of third stage of labor, an open label randomized trial. Again here IV carbetocin and IM oxytocin. Outcomes were almost the same, and the results are primary PPH was not there in carbetocin group, oxytocin 6.4, massive blood loss, none with carbetocin, 8.5% with oxytocin. Immediate transfusion was not required in carbetocin, and also the additional uterotonics, whereas it was required in oxytocin group. Average amount of blood loss, I think there was not much difference, but all other parameters were assessed, which definitely showed a better outcome. So carbetocin appears to be an effective new drug in the active management of third stage of labor in vaginal delivery and can be considered as a good alternative to oxytocin in AMTSL in normal vaginal delivery. Following cesarean section, again randomized control trial comparing carbetocin, misoprostol, and oxytocin for the prevention. Oxytocin 10 units following neonatal delivery, and then 20 units in 500 ml saline for 4 hours, and misoprostol was 400 sublingually. And primary occurrence was again occurrence of uterine atony. Results, again, definitely carbetocin has scored better than oxytocin and misoprostol. Comparing the blood loss is comparable with oxytocin and carbetocin, more with misoprostol. But definitely the requirement of blood transfusion was not there in the carbetocin group. So we know that it has fared better. Then there are so many studies where again they have studied for need for additional uterotonics, blood loss, and requirement for blood transfusions. So same here, very less need for additional uterotonics. Postpartum blood loss is also less compared to oxytocin, 437 ml and 721. And blood transfusion also only 3% in carbetocin and 13.3 in oxytocin group. Following cesarean delivery again, okay, oxytocin, even combination also, the carbetocin has fared well comparatively, but with combination, definitely it has worked better than only using single oxytocin or misoprostol. So they found that it is superior over combination of oxytocin plus misoprostol. Coming to ergometrin again, here again, what the 200 women for elective cesarean delivery, carbetocin 100 microgram, oxytocin and ergometrin combination. There also they found that with carbetocin, need of additional oxytocin was less, with combination also 48% required, and less atonic PPH, okay, with carbetocin. So all these studies definitely prove the superiority of the carbetocin over all this. And this is the Cochrane review. The carbetocin resulted in a statistically significant reduction in the need for an therapeutic uterotonics compared to oxytocin, with less blood loss and significantly fewer side effects. Okay. I think for pain perception, I think there's only one study, but I think that we will have to really need to study more to see whether really why there was a less pain, a reduced pain perception in women with a high risk of postpartum hemorrhage with carbetocin. Then for prevention after cesarean, again, all these trials, definitely carbetocin is faring better. Okay. Then for prevention in patients with severe preeclampsia, again, the primary outcome measures were assessed here also. Oxytocin in 20 units in 1 liter and carbetocin. Okay. And they also compared and found that carbetocin is an appropriate alternative to oxytocin for the prevention even in severe preeclampsia. It appears not to have a major hemodynamic effect in women even with severe preeclampsia, and it uses a low volume per dose than oxytocin, so it should be considered a valid option in the management of third stage of labor in women with hypertensive disorders. Comparison with carboprost. Carboprost is second line, carbetocin is first line agent, not recommended by WHO. Carbetocin is recommended. side effects are, we know with carboprost, vomiting and diarrhea, no such severe incidences and contraindicated in asthma. But if there is any history or anything, it should be, even carbetocin should be used with caution. Okay. So third stage of labor in patients with single-term pregnancy, in with high-risk pregnancy, and elective section or high risk, and patients with twin pregnancy also. It proved superior over oxytocin and other uterotonics with respect to prevention of PPH, blood loss, need for additional uterotonics, decrease in hemoglobin levels, need for transfusion, perception of pain and side effects. Indian scenario, I think Dr. Poonam is here and she is a champion, one of the champion for this champion trial. So this was the trial which was conducted by the Belgaum Medical College, and which happened in 10 countries, and it happened in 5 centers in India. And this was carried out by WHO for carbetocin versus oxytocin, 23 centers in 10 countries, including India, that is heat stable carbetocin versus oxytocin. Okay. And these are the centers in India. And I must tell you, even UP, I think Banaras has participated. And these are the other hospitals, 2 from Karnataka, Nagpur, then Banaras, BHU University, and Maharashtra. Okay. It proved to be non-inferior to oxytocin with ease of single dose administration. So in summary, it is superior or oxytocin with respect to all the factors we just saw, even with ergot alkalides, and even with carboprost and misoprostol. So carbetocin, most efficient uterotonic and was most awaited uterotonic, and it has arrived now. So all of us have started using it and experienced, and we know that definitely it works better, because as a single dose, the uterine contraction, which is sustained and which lasts for a longer time. Thank you very much for your patient hearing. I will stop the share.
Thank you, Sheila. It was a really wonderful presentation, and I think each and every point you've done so beautifully. I think all the people who have joined really must have really gained a lot of knowledge about it. And carbetocin, you've taken it so beautifully. I think I had the same experience that about 2 to 3 women out of 150 needed some extra support. Otherwise, it was wonderful in vaginal as well as cesarean. Cesarean cases, I think it was really wonderful. In fact,
Yes,
there was
madam.
no blood loss at all. You didn't need anything else. So if there are any questions, I think I will tell the moderators to find out. Do we need to do the question answer now or at the end of this?
Ma'am, we can take it at the end of the session.
Tanushree?
Yeah, yes, ma'am. I am writing down the questions in the chat box. I think we can take the questions at the end of the session.
Yes, that would be good.
And I'll request our respected speakers to be there till the end, so that the question answer session can be discussed, ma'am.
Okay.
हमें छोड़ के रखना
पकड़ लिया गया
हमें हम तो नहीं बचे हम गायब हैं
कहाँ जा
Thank
रही
you
हैं
so much, Sheila
मैं
ma'am.
आप ही
for
तो
an
आप
excellent-
सबसे ज्यादा यूज कर रही हैं
चलिए अभी आगे का डॉक्टर अतुल सर का इनवाइट करूं.
Thank you so much, Sheila ma'am, for an excellent and elaborate talk.
Thank
And
you.
I also thank Chandravati ma'am for her valuable inputs and for blessing us by her gracious presence. And now I hand over the session to my co-convener, Dr. Tanushree Gupta ma'am, for further proceedings. Thank you so much.
Thank you, Fatima. Thank you for that excellent session. And now, good evening and a warm welcome to all my seniors and my colleagues. We all know that PPH is a major contributory factor for the maternal mortality, though with the efforts of us Foxians, I think, and us obstetricians, we have been able to reduce the incidence. And I'll take this opportunity to really congratulate Dr. Preeti, who is chairperson of the Safe Motherhood Committee, along with, in collaboration with JAPICO and the Pathfinders. She has taken up the project, launched the project Jeevan Dhara, and we had the privilege of being a part of the project, and it is really, really wonderful. Training every medical and paramedical staff so that the incidence of PPH can be brought down, and whatever PPH is there, patients of PPH is there, they can be managed in a better way or transferred to higher centers in a better way. Really, Dr. Preeti, thank you so much.
Can I just add one thing?
Yes, ma'am, sure.
We had Dr. Paul as a chief guest for the ICOG convocation, and he was stressing upon that we have to train the health workers. And
Yes,
I really felt proud at that time about Dr. Preeti, that she has really taken the initiative, and where, you know, mostly the concentration is on health workers, because they are the key persons who are there always in the labor room. So
Very true, ma'am. Very true.
I think
Thank you so much.
We had been a part of a project. We had the privilege, and really the way she has taken up the project and trained even our paramedics, we are really thankful to her for that.
Yeah.
Thank you so much.
Now, having heard the medical part of the of management of the PPH, now I think we can move on to the surgical part of managing the PPH. And for the next session, I will request Dr. Uma Singh ma'am to chair the session and to officially introduce our next speaker. Though Dr. Atul, he doesn't need any introduction, but still I'll request ma'am to take over as the chairperson of the next session, ma'am. Dr. Uma Singh ma'am.
Yeah, so it's a matter of great pleasure for me to be present in this session, the day when, you know, we are celebrating Republic Day of our country, and it's again a very cold day in North India, but the warmth of the webinar will, you know, go all over and spread the, you know, the sentiments of the program for which it is being organized. It's a great pleasure for me to introduce Dr. Atul Ganatra. I think besides everything else which I'm going to say as per the CV slide, he was a great friend of Lucknow Obstetrics and Gynae Society in his tenure of Vice President of FOXY in 2021 phase. And if you all remember, that was the time when we organized the famous AICOG, and he was always there with us to support us. He is Joint Secretary of IAGE, Chairperson, MTP Committee of Maharashtra Obstetrics and Gynecological Society in the year 2012 and 2014. He's in the Managing Committee member of MOGS again, and he's in the Medical Advisory Committee of FPA. Apart from everything else, he is the director of Ganatra Nursing Home and IVF Center. And it's a great pleasure to have him today to speak on surgical aspect of management of PPH. Dr. Atul Ganatra, a multifaceted great friend of LOGS. Welcome to this webinar.
Thank you very much, Dr. Poonam. It's an honor to speak in Lucknow. I got installed in Lucknow, and I think the world famous Dr. Preeti Kumar, now I'm going to call her PPH Preeti, and is from Lucknow. Chandravati ji, teacher of teachers. My own teacher, Dr. Sheila Mane, it's an honor to speak. I was her student in MBBS, and I think one of the reasons why I took up gynecology. So it's an honor to speak in front of the entire Lucknow team. I'm wondering that Lucknow Society is doing so much work. Should I ask for an additional membership of the Lucknow Society? So I'll just share my screen.
I think
you
you're right,
most
Atul.
welcome. You are most
You're
welcome.
right, Atul. I think we should become a member.
Is my screen seen now?
Yes, sir. Desktop.
Yeah.
Yes, sir.
So the Lucknow Society is doing so much work. I think Baki sab society ko complex aa gaya. And of course, world famous Dr. Preeti Kumar. First, I used to say world famous in India. Maine wo baat change kar liya. Now she's famous in ACOG. She's famous in UNICEF, WHO. Baki sare to naam bhi mujhe nahi pata hoga. So thank you very much, and it's an honor and privilege to be talking on the surgical management of this august group. And I must apply, if I don't know if my CV gives me permission to join this club, but I will definitely send in an application. My talk is going to be divided in two parts. The first part is going to say how we can anticipate and prevent PPH. So I'm going to show you some cases, and then we'll talk about the surgical aspect. And I think this is a very, very important quote that every one of us must know. We don't grow when things are easy. We only grow when we face challenges. Of course, hamare baal thode safed ho jayenge, but we will definitely grow. Look at this patient. This is a Pliny, husband and wife, deaf and mute, RH negative, were referred to us after PPH, a hysterectomy. A hysterectomy was already done. And in spite of the hysterectomy, you can see that there is so much of bleeding in the drain. They were deaf and mute. We could not talk to them. This happened just about April this year when the second wave was very, very active, last year rather. When she came to us with her anesthetist intubated, she had no pulse or blood pressure. Her HB was 2 grams, INR 1.9, platelet 40,000, fibrinogen 45, lactates 12. Remember, lactates, anything above 2 is dangerous. She was in a state of hemorrhagic shock. COVID test not done. April 2021, Delta wave in Mumbai was very active. COVID test not done. When I was sent this call, there's a very dear friend who referred this patient to me. She was refused admission in a private hospital. So the emergency team at Fortis Hospital is now so good at managing PPH. The team immediately gave her crystalloids and colloids. Within a few minutes, we got a CT angio done as soon as we could feel her blood pressure. And you can see on this that the ovarian artery was bleeding. Here you can see the ovarian artery. She arrested in the ICU. We gave her 12 PRBCs, 20 FFPs, 20 cryoprecipitates. The interventional radiology team went ahead and kind of embolized the right ovarian artery. And when they called me from there and they said, we finished the right ovarian artery, the bleeding has stopped. Do you want me to go ahead and do the internal iliac? I said, please do it, because anyway, she doesn't have a uterus now. There is nothing else that we need the iliacs for. We managed to save her and send her back to her primary gynecologist in 3 days. The second patient here, as you can see, central placenta previa. This is somebody who was referred to me. This is managed just about last month. The principle, take your incision above the placenta previa. So we went ahead, delivered the baby. The placenta was right up to here. Obviously, we closed this layer, but she started bleeding from here because the placenta was there. We took multiple Cho sutures. The bleeding reduced but did not stop completely. As you can see here, multiple sutures taken. I'm going to show you what the sutures are. We also did a Beelinch because we were not sure that the bleeding had stopped completely. Remember, sometimes in this situation, it is better that the patient's legs are a little wide apart so you can see if she's still bleeding once you close this. So once we took these sutures, we opened the scar again, assessed the bleeding, that the bleeding had stopped, and then closed this again because we wanted to save blood. We went ahead and did the internal ligation, which I'm going to show you a video of. And this patient had an uneventful recovery. We had to just give her 1 pint of blood, central placenta previa. Now I'm coming to some old cases of mine. A P2L2 referred to us after having diagnosed as placenta percarita on USG and MRI. She had 2 LSCSs already. As you can see here, the placenta had already crossed and penetrated the serosa. And what we thought was the UV fold of peritoneum here, we opened. What we were thinking is the UV fold of peritoneum was the bladder. We opened the bladder here. That gave us some sense. We went ahead, took a vertical classical cesarean scar, removed the baby, and straight away went ahead and did an obstetric hysterectomy because this was a 3rd pregnancy. Here, if you mess with the placenta, we had already opened the bladder. Obviously, the bladder had to be closed again. I don't think there's any room to do any conservative surgery here. And all this consent has to be documented either with a video call or with a written documentation. But all of us have good telephones now. Please record your consents, especially in critical situations. Case number 3, dentist, 35.6 weeks, placenta increta, gestational diabetes. She had 1 cervical ectopic, 2 LSCSs, 1 open myomectomy, 1 lapsed cystectomy for endometriosis, which said on MRI that the ureter looked filled up. This is the ultrasound picture of the placenta. We could not see a line between the placenta and the bladder. And this is the picture when we opened up. Obviously, here we learned that vertical incision is mandatory. This is the lower segment of the uterus. There was no UV fold. These are the vessels that you could see, and God save us if we had to incise anything close to this. We took a vertical cesarean scar, we delivered the baby, and before delivering the placenta, went ahead and did a hysterectomy straight away. Again, every consent on paper with a video call. Case number 4, an LSCS with 21 weeks of pregnancy. Again, placenta accreta or previa. They were not sure. We could see this line very, very clearly. Very important that you read the ultrasound film and not the report. We went ahead again, as you can see here, the lower segment. Again, patient had 2 children. We went ahead and did a subtotal hysterectomy. This is the lesions, uterus at the end of surgery. Anticipation, preparation, documentation, imaging, hemoglobin, blood. I think these are the key to managing a situation. Another patient, central placenta previa, primi gravida. We did not want to remove the uterus. We went ahead and did a balloon placement through the femoral artery into the internal iliac artery. We blocked the balloon, delivered the baby. The ooze continued. We had to deflate the balloon after the baby came out. Obviously, the balloon was occluded. We put in the Bakri balloon, sutured over the Bakri balloon, kept the Bakri balloon in place for 24 hours. Anticipation, very, very important. Another patient with multiple fibroids referred to us with acute pain abdomen. We had to take her up as an emergency. She had history of multiple fibroids. You can see there is torsion of this fibroid here, which was causing the pain. And once things had settled, we thought since we've removed one, we'll remove all the fibroids. We did bilateral internal iliac artery, but remove all the 7 fibroids on the patient. So postpartum hemorrhage represents one of the main causes of maternal morbidity, mortality, approximately 25% of deaths. And the golden hour aims to reduce morbidity and mortality. There are 3 golden hours.
Sir, unmute, please unmute. Yes.
Was I heard so far or was I not heard? Hello?
Yes, sir, you were heard.
The golden hour says 20 minutes. आप एक बार abdomen खोल के 20 मिनट रुक के देखो. 20 मिनट बहुत ज्यादा लंबे होते हैं. Patient इतना survive नहीं करेगा. So I would say 5 minutes. My golden hour is 5 minutes. First 5 minutes, medical treatment, fluid replacement, management, the main cause of bleeding, of course, stone tissue trauma and thrombin. Second 5 minutes to perform medical maneuvers, including uterine artery tamponade, compressive sutures, pelvic sutures, vascular sutures. Of course, if you have the facility of the pneumatic anti-shock garment, you can use it. But आपके पास total में 20 minutes से ज़्यादा time नहीं है. The patient bleeds like a tap. Conservative surgical management will include, you can take hemostatic sutures, you can ligate pelvic vessels, and if finally nothing works, you may have to do a hysterectomy. So look at the situation. If it is uterine atony, the bilateral uterine artery will work well. The Belan suture will work well. The Cho suture will work. We are going to talk about every one of them. The Heyman and the Pereira is excellent. In placenta accreta, of course, all of these will work, and you may have to use all of them. In any trauma to the cervix, none of these methods are going to work. The Cho suture may work. The uterine artery is poor and ineffective ligation because the blood vessels are vaginal vessels. And selective low vascular ligature is an excellent method. So I think you need to understand kahan se bleeding ho raha hai. Where is the bleeding from? So you divide that pelvis into 2 parts. You have S1 and you have S2. S1 is above the fundus. And S2 is the lower aspect. Is that trauma to the vagina? Is that trauma to the cervix? So you need to define in about 2 or 3 minutes as to where the patient is bleeding from. Patient at imminent risk, and if you don't have any facility, the aortic compression, this Dr. Shiramani spoke about it. These are the 2 places where you can do aortic compression. Sorry. And this is the Piley's aortic clamp. Every gynecologist must have this clamp. And mind you, it is a vertical incision because you cannot feel the aorta with such a large uterus. The incision is transverse. So you may have to sometimes take an inverted T incision. Balloon occlusion of the aorta, we've already shown you. If you have a interventional radiology team, a cath lab, you can do that. Go through the femoral artery, go into the iliacs, drop the internal iliac. Uterine tourniquet is a kind of a simple rubber catheter which you can apply as low as possible around the lower segment without incorporating the urinary bladder. And then the 2 ends are pulled in the direction as like this. You can use just a rubber catheter like you use the Bonnie's clamp or you can use the bone is mimetic. You can apply one here also because the ovarian artery also bleeds. You can use the Bakri balloon. You can use a condom catheter. You can use the ebb catheter. You can see this ebb catheter has a lower vaginal portion because if there is bleeding and laceration in the vagina, this catheter is very, very. Now there is an Indian company which is manufacturing this also. Conservative surgical management. UCS, that is applying sutures. Conservative sutures is extremely important. If it is S1 category, certain sutures can be applied. If it is S2 category, the other sutures will be useful. And 80% of patients can be saved by just doing that. The B-length sutures, I think it's very, very simple. If it's a cesarean section, you take a bite in the upper segment, take it here, take the uterus all around, go back, take a transverse suture and come back in front and take a suture over here. This is extremely effective in most cases if the placenta is fundal, as you can see here. Heyman's compressive suture. This is taking two separate sutures, going anterior-posterior. I don't know if you can see me. The B-length suture goes from here to here, goes behind you, take a transverse suture, bring that suture up and suture this. Whereas the Heyman's suture, you go from here, come out posteriorly, take it up and suture it at the fundus, and two separate sutures. And then you take an anterior-posterior suture. This suture, you go through and through the uterus, anterior to posterior, come out, again posterior to anterior. This is very, very useful for lower segment bleeding. Cho's compressive sutures. I think this is very, very important. The only thing is that you must see to it that you dilate the cervix. When you take transverse sutures, you go anterior, posterior, posterior, anterior, again anterior, posterior, and come back. And you apply 4 of these sutures. Along with a B-length, you can apply this, and this is going to be extremely effective in upper segment and a little lower segment bleeding. I think the ureter is too far away. Once you've dissected the UV fold, it doesn't come in your way. The Pereira's compressive sutures, you don't go through. It is a suture which stays in the serosa. The Pereira's technique, it is taking several continuous sutures without penetrating the uterine cavity. This reduces the risk of infection, synecdoche, and also intestinal entrapment. So you take vertical sutures like the B-length sutures, but you don't penetrate, and you take transverse multiple sutures, make sure the ureter is in place. This is a MY technique, very famous, the MY technique, which keeps a Foley's catheter or a Buckley balloon inside, and you take sutures by the side of it. This is to keep the uterine cavity patent. And if you have placenta previa, then you need to take these transverse sutures. You go all around, go anterior, posterior, come back anterior, go posterior, and take multiple sutures. Yes, it may cause secondary infertility, but I think a patient like this, if she's bleeding heavily, we don't have a choice. And you could keep a Foley's catheter to keep the uterine cavity patent again. Again, ligation of these pelvic vessels. You can ligate the uterine artery at 2 levels. You can ligate the ovarian artery, the O'Leary technique. There are 4 places where you can ligate it. The uterovarian ligament, you can ligate the vessels here. You can ligate the uterine artery over here. And the Morel step-by-step ligature. I think this is the most important one. The first step is to perform a distal uterine artery ligation. The second step, the round ligament ligation, rather than the infundopelvic, because it doesn't compromise fertility. The third step, the uterovarian ligament. The fourth step, if there is persistent bleeding, a proximal or the uterine artery ligation at its origin. And finally, the hypogastric artery. So these are the 4 steps. First step, uterine artery. Second step, round ligament and the O'Leary technique, that is stepwise devascularization. And nothing works. You'll have to open the broad ligament and do the uterine artery at its origin. And finally, the ovarian ligament, the internal iliac artery. Again, I think this is one technique which every gynecologist has to know. And I'm actually pleading Dr. Preeti Kumar that we must have workshops on this. And trust me, I have done only 25 so far, but it takes only 3 minutes to do one. And you're going to see that in this video now. See this broad ligament. You just need 2 T-verse forceps, 1 mixed up. and a good assistant, or maybe a 3D burst forceps. You can just open the area between the round ligament and the tube. You could just use your finger or a sponge in a holder to open this area. The only structure that you need to identify is the ureter. It opens beautifully. The uterus has to be pulled upwards and towards the spleen by your assistant. 2D burst forceps. You use a disposable suction. The tip of that disposable suction is blunt, and you can just see the structures right there in front of you. Trust me, really, really not difficult. All you need to know is the ureter. This is the ureter. These are the vessels. And the internal iliac artery is down there. All you need to see is identify this ureter. Pick up the internal iliac artery. This is the external iliac artery. Pick up the internal iliac artery. And do this in a cesarean where you will not ligate it. Take a mixer. Always go left to right because the iliac vein is just below that. Go left to right, or lateral to medial rather. Pass the artery. Do not dig. Do not use pressure. Be very, very gentle. Remember, the artery, you cannot puncture an artery. You can tear a vein, you cannot tear an artery. They are two strong structures. Instead of using the forceps here, we use a disposable suction to create the space. Get a vicryl, wet it. Let your assistant pass the catheter suture. And while this is being placed, do not use dry vicryl. Let somebody pour some 5 cc saline or 5 cc distilled water with a syringe to keep that area dry and to wet the vicryl so that it stays properly. Be very gentle. You can use a Babcock here instead of using the Alice forceps. This is in a workshop which we had at Fortis Hospital. And this is how I trained myself. You don't have to do this. Just pass the suture and leave it at that. And unless you do it in a normal case, you're never going to be able to do it. And trust me, it takes exactly 3 minutes on one side. Post-op bleeding. If you have finished the hysterectomy and the patient is still bleeding, you don't have the means, take 6 to 7 towels, wet them and push the towels to create tamponade into the pelvis, keep a drain and send the patient. Unfortunately, I couldn't find a video of one of my students who did this, and we opened up the patient 2 days later and just removed the mops. We just managed her DIC for about 48 hours. Knowing yourself is the beginning of all wisdom. Training yourself is improving your wisdom. Thank you very much for the patient hearing. I hope I didn't exceed my time.
No, sir. Uma ma'am.
So amazing. Yeah, amazing. It was absolutely
I think she's muted.
mesmerizing.
Dr. Uma Singh, we can't hear her.
You can hear him. Ma'am, we can hear him.
So, so, it is only those who deal with placenta accretas day in and day out know the nightmare of placenta accreta. And you have so inclusively talked about so many methods, right from simplest ones to high-end where tamponades, and to high-end where intervention radiologists' help can be taken and they can be used. Thank you so much. You made that all sound very simple, but those who deal with placenta accreta know. But yes, the measures you have advised really go a long way. If you just keep kind of calm, remain cool, use all your knowledge, and actually take help of all those people present around you. As a teamwork, if you proceed, you are able to save a lot of morbidity, at many times mortality, and very often a lot of complications also. Thank you so much, Dr. Ganatra. It's been great. And I'm sure there would be a lot of queries which the organizers would ask later on, picking them up from the chat box. Thank you once again, Dr. Ganatra.
Thank you. अब प्रीति जी शायद मुझे नौकरी दे देंगे.
No, sir, I really want to thank you, sir, and I must put on records that whatever work Safe Motherhood Committee has done in year 2021, I think you had been a pillar of strength for Safe Motherhood Committee, and the Dr. Atul Ganatra sir managed to contribute to 1,500 gestational age calculators for the healthcare workers and anemia calculators for the doctors. So all credit to him, and Tanushri, Fatima and Jyoti, the healthcare workers have received those gestation age calculators. These are all arranged by Dr. Atul sir. So he's the person who actually works and encourages behind the screen. And he always, sometimes I get demotivated. He's the person who tells me, just go ahead, do your job and leave it to God. So thank you so much, sir, for being there always with the Safe Motherhood Committee and with all of us. And we always need your support and guidance for our future endeavors. Thank you so much, sir.
I'm a grassroots worker and I will continue to work. Thank you.
Thank you, sir, for that excellent presentation. And I wish we
चंद्रावती
could
मैम
have
कुछ
more.
बोलना चाह रही हैं, डॉक्टर चंद्रावती मैम कुछ बोलना चाह रही हैं। मैम बोलिए, आप कुछ बोलना चाह रही थी।
हाँ जी, इसलिए बोलना चाह रहे हैं कि अतुल को देख के याद आता है, पुराने दिन याद आ रहे हैं, इसलिए अतुल थैंक यू फॉर बीइंग हियर।
मैडम आशीर्वाद देते रहिए बस कि काम करते रहें।
सर, वी एश्योर यू, अगर ये कोविड का खत्म हो गया, वी विल डेफिनेटली ऑर्गेनाइज सम वर्कशॉप्स ऑन इंटरनल एलिक लाइगेशन।
God willing, God willing. I
फिर
wish we can
करवाएंगे,
do that.
बिल्कुल इकट्ठे करके रखेंगे।
You made
अभी
it
झेलने
so
जा
easy.
रही हूं मैं केस, ठीक है।
मंजू जी बहुत इजी है, बता रहा हूँ आपको, हमको जब
अरे
डर लगता
भैया,
है।
आपने तो ऐसे करा ना कि लग ही रहा था बहुत इजी है।
और सचमुच में इजी है, कोई दिक्कत नहीं है उसको करने में। आई प्रॉमिस यू कि लखनऊ सोसाइटी का सीनियर से हर बच्चा ये कर सकेगा और करना बहुत आसान है। हमें सिर्फ कंसेप्ट क्लियर करना है, हमारा फियर निकालना है।
एक बार वर्कशॉप होएगी ना तो नॉर्मल
एक हफ्ता रोकेंगे अतुल को यहीं पे।
हाँ
ठीक।
थैंक यू।
थैंक यू सर।
थैंक यू।
थैंक यू मैम।
Thank you, sir. We wish we could have more of the cases, but because of this time constraint, I think we'll be moving on to our third session. And the third session is also very interesting one. That is the alternative birthing positions. May I now request Dr. Manju Shukla ma'am to chair the session and to introduce our next speaker to our august audience.
अरे मेरे ही हटाओ।
अनुश्री, एक बार we will have a session on critical care cases. I can show you as of now 126 cases like this.
Sure, sir.
We will have a
presentation was so interesting. We will like to have more of that, sir.
God willing, we'll do
और एक आपने सर प्रेगनेंसी, कोविड विद प्रेगनेंसी का जो बात की थी सर, इफ यू वांट वी कैन हैव दैट सेशन आल्सो सर।
anytime.
ठीक सर, थैंक यू सो मच सर।
थैंक यू सर।
चलो, अब वो उसका हैंगओवर खत्म हो गया हो तो नया। आवर नेक्स्ट स्पीकर इज डॉक्टर पूनम वर्मा। इतनी सारी ये लिख रखी हैं। शी इज प्रोफेसर एंड हेड OBGY MGIMS सेवाग्राम वर्धा, and she is a very good friend of mine, distant friend है, and she is involved in many trainings, many projects. She is involved in advanced training in SHRH from Uppsala University, Sweden, advanced training in obstetric HDU ICU Foundation, Cali, Colombia, NTTC ZIPMA clinical skill trainer, training for EMOC CMC Vellore, core member of PPH working group, FIGO president, SWOGS, principal investigator for e-partography, JDF USA, stillbirth and pre-viable birth defect project, WHO, zero low-cost salivary progesterone for predicting preterm birth, all children thriving grand challenge, Bill Melinda Gates Foundation, EMOC and PPTCT, and co-investigator for hypertensive pregnancy in community, ICMR and non-surgical
मैम आप ऐसे ही इंट्रोड्यूस कर दीजिए बस.
अरे पूनम, तुमने तो सारी चीजों में तो तुम इन्वॉल्व हो, और बड़े बड़े नाम है, जरा
मैम
पढ़ने
बस
में
ऐसे
टाइम
ही
लगेगा
बोल
ना.
दीजिए, हम शुरू करेंगे.
अभी रिसेंटली जो पीपीएच बंडल, तो she is known as PPH lady also, like Sheila. ठीक है, तो she is going to talk on alternating birth positioning, जिसमें mainly underwater birth. She has
पूनम
done
को इतना
many
डिटेल में
cases.
मंजू क्या इंट्रोड्यूस कर रही है. पूनम तो ऑल ओवर नोन है.
हाँ, तो वही तो.
पूनम को क्या इंट्रोड्यूस करना.
हमारी
पूनम का
दोस्त
नाम
बन
बोलो.
गई.
पूनम इंट्रोड्यूस्ड है बिल्कुल.
पूनम एग्री तो करो कि मेरी दोस्त हो.
मैम
तुमने
आपके
तो
you know, everyone would like to be a gynecologist like you because you are so witty and always smiling. It's such a pleasure to say that you are my friend. So should I share my slides, ma'am?
Yes, yes, please. नया टॉपिक है, नया इंटरेस्टिंग.
है?
Yeah, it's visible, ma'am. Full screen कीजिए.
Yes. Is it visible now? And please tell me if it is moving.
Yes, yes.
Very
Very well.
All of you. Wonderful talk of Dr. Sheila and Dr. Atul Ganatra. Really so much to learn with each presentation. I first would like to thank Dr. Preeti and the whole team of Lucknow for inviting me. My topic today is alternative birthing positions, which is probably an important component of RMC. So I bring greetings from Mahatma Gandhi Institute of Medical Sciences, an institute which is in the rural area, but trying to do the best for the rural women and treat them exactly the way they are treated in corporate hospital when they are rich. Our concept is that respectful maternity care is the need of the hour, and one of the very important component is alternative birthing position. So I have divided my presentation into topics, a little bit more about alternative positions, then talking a bit about the literature about it, and moving from history to the evidence, and then sharing with you our own experience. So when we talk about alternative birthing position, we all know that labor is a very emotional period. There's unbearable pain, but at the end, there's happiness and joy. The first and second stage of labor is most difficult. And if we go into the research, the first stage has latent and active phase, where active phase is more troublesome. And in second stage, there's propulsive and expulsive phase. And there's extreme pain, which is experienced during these periods when the baby is coming out. Why are we talking about alternative birthing positions? Because changing position not only helps the women to cope up with the pain of labor, upright position also have some effect of gravity, which probably bring down the baby much better. And where, while changing the position, also move the bones of the pelvis, and it helps the baby to find the best way to fit. And this has been confirmed by these authors. There have been a very interesting history. The traditional birthing position has changed over time. Cleopatra gave birth in the kneeling position, which was years ago. Babylonian women did that in the chairs nearly 20th century before. And for the last 200 years, most of the American women, they deliver the baby while they are flat on their back. So there have been some very interesting history. And if we look into these positions, several positions have been used age old. And yet we are coming back with the evidences to those positions just to give the comfort to the women. Now we are moving from history to the evidence. Let's talk, what do we want to do during birthing? We want to help and ease the discomfort of the women. We want the baby to move down through the pelvis as early as possible and encourage fetal positioning in such a way that when the baby comes out in such a way that baby breathes in the best situation. So birthing positions have been classified as one upright, where it is the pelvis which is straight or the bones are straight, and there's non-upright where she lies either on the back where the spine is at rest. Now, when we talk about birthing position, to give these birthing positions, we need several props, and these are birthing chair, bar, ball, or hydrolab. When we talk about these alternative birthing position, we all know that we have kneeling, standing, hand and knee, side lying, squatting, using U-shaped birth seats, hydrolabor, and all these come under flexible sacral position, where you take off the weight from the tailbone. And there are some where they rest on the sacrum. So these are non-flexible sacral positions, where one is supine, which is with or without head end of the bed raised, dorsal positions, semi-sitting positions, or lithotomy positions, where we tie our women with the stirrups. Now, when we talk about birthing positions which are upright, research says that birth in upright positions have been really favorable. Several physiological reasons like gravity helping the baby to bring it down, less risk of compression of mother's aorta, so better oxygen supply to the baby. Uterus contracts more strongly and efficiently. MRI dimensions, when it was seen that the pelvic outlet becomes very wide. Also, upright birthing position, they increase maternal satisfaction and they lead to more positive birth experience. Coming on, sitting on the chair, the pros of this particular birthing positions with the chair are that it helps to relax the perineum. The women gets used to an open leg position and pelvic pressure. It uses gravity. Women can pick up their baby and latch him or her on her. And then the cons are that pressure from toilet seat may cause slightly uncomfortable situation, but then that can be obviously managed by using different variety of seats. When we talk about ball, again, when a woman is holding ball, few things are that one, it reduces her pain significantly because she can hold on the rope, use the ball and roll over the ball and reduce her pain. It uses gravity, gives good oxygen to the baby. Contractions are more efficient and less painful. It speeds the labor, helps to create a pushing urge. But problem with it is that many a times it's difficult to control the birth, and it is hard for the healthcare provider to sit with the or to hold the baby while the baby is coming out. Now, birthing positions, when we talk about the bars, again, it aligns the pelvis and increases the opening. It allows a lady to be supported, takes advantage of gravity, makes contraction feel less painful. It lengthens the trunk and helps the baby, and the movements help the baby through the birth canal, and it may increase the urge of passage in the second stage. There's a literature review all around the world. That still people are preferring non-upright positions, but current obstetrics textbook also state that it is beneficial to push the baby when the baby is in upright position or the woman is in upright position. Now, let's come on to what are the pros of lying down position. Again, it does supply oxygen to the baby. The mother is resting well. It helps slightly if you have elevated blood pressure. When you have given epidural, it can help. It can make contractions more effective. It's easy to relax between the contraction. It can slow a birth that's moving too fast, partners can assist, and it lowers the chances of tearing because you can give good episiotomy, which now is not a recommendation, and there's good access to perineum. However, cons are that it may be hard for the healthcare provider to access fetal tone, to help, there'll be no help from the gravity. If one does not hold the legs properly, you may have difficulty in delivering the baby, and you may feel too passive in this position. Intermittent auscultation of baby at regular interval can be done in this particular position, especially when you talk about semi-sitting, and continuous electronic feeder monitoring also can be done. But then, of course, nowadays we are not really recommending continuous monitoring because we all know that the issues which are coming up are increasing rate of cesarean section. When we lie on the sides, again, this is another position which has been said, but then again, it is sacral resting position. And the evidence is that giving birth in this position also helps the baby to have good oxygenation. It reduces the length of active pushing. The rate of episiotomy and use of forceps vacuum or fundal pressure, all that is absolutely not there in this position, because these are, if you talk about episiotomy and fundal pressure, these are not recommended techniques. Semi-sitting in bed is easier for caregiver to access abdomen to monitor the fetal heart rate as compared to this position. These are some more positions which have been used. One is knee chest position, which is very good for back labor, assists with rotation of the baby, takes pressure off hemorrhoids, good position to avoid tearing or episiotomy, good delivery position for large baby. But again, the team has to know how they have to do. And I would like to talk to you about this hydro labor. There's a huge evidence available nowadays. The hydro labor, what we have done also, we have come out with the very interesting fact, which I will share with you in a minute. Stress hormones are reduced and pain relieving chemicals are released in excess. Labor pain is reduced markedly. And surprisingly, it really shortens the duration of first stage of labor. And when the baby comes out and immediately you put the baby on the mother's abdomen, you will see that placenta comes out in a minute. It reduces the incidence of instrumental delivery and also cesarean section. Now we go on to the literature now. After seeing all these positions, the Cochrane review and meta-analysis combined result of 32 randomized controlled trials, which has included more than 9,000 birthing people. You will see that these are the results, that 25% less likely to have forceps and vacuum assisted birth, 25% less likely an episiotomy, 54% less likely for abnormal fetal heart pattern, so reduced cesarean section rates. But there have been 20% more second degree tear, which is actually good because you're not giving episiotomy, and a slight more blood loss as compared to the birth which are with the dorsal position. Now, these are the evidences which I have taken and I have seen, and with that I have written the facts which are there. So one can go and see these hydro labor pregnancies, hydro labor being used in two ways. One, as hydrotherapy for reducing the pain and decreasing the duration of labor, and second, delivering the baby underwater. If we go into the US data, birth lying on their back are nearly 68%, semi-sitting 23%, side lying 3%, squatting sitting 4%, and hand and knee 1%. So you can see that yet we haven't reached the level where we can, these alternative birthing positions are accepted even in the developing world. There was one more meta-analysis which I came across, in which the people with epidural being upright during second stage of labor, But then they said that there was no difference in the rate of cesareans, forceps vacuum, perineal tears, and abnormal heart rate pattern, low cord pH, or an ICU admission. ACOG recommend for most people giving birth, no one position needs to be mandated nor prescribed. It also states it is normal for people in labor to assume many different positions and that no one position has been proven best. So the women should be given the choice or freedom of movement in labor, and she should decide which position she wants to deliver in. RCM also, there's a statement that there are variety of props available in the room which can take different position. One should have bean bags, mattresses, chairs, birthing balls, so on and so forth, and let her decide whether she wants to be upright or she wants to lie down. WHO concludes that women in labor should adopt any position they like, while preferably avoiding long periods of lying supine. And these are the references, which is clearly states that different positions probably are coming in, and we must think about the alternative birthing position. And midwifery have been the first one which have been using this. And very proudly, I would like to say that in India, we have Fernandez Hospital in Hyderabad, and they are the ones where actually we also went and got trained, and we started doing alternative birthing position. So I'm just now coming to the last part of my presentation. I'm sharing with you how we did alternate birthing positions and what are our results. So this is our maternal and child health wing, which Government of India provided us to make a model wing, and that is being replicated all over India. I'll just run through that. These are our teaching areas and ST rooms, antenatal counseling rooms. These are our antenatal wards, HDU, ICU, and labor room. These are our labor rooms, and these are absolutely LDR, labor delivery recovery rooms, where you have to have two laboring tables, and then you have to have a toilet in between and a nursing station right in front. So we are following Government of India guidelines. We have our own high dependency unit where single organ failure people are being kept. And this is our intensive care unit where multi-organ failure, ventilation, and defibrillators are being kept. These are our operation theaters, which are modular. And you can see that this is just a will to do respectful maternity care, because we are in the most interior part of the Maharashtra. And we are just trying that our women, rural women, should get the similar care which a rich woman is receiving in the corporate hospital. We have neonatal ICUs with level 1, level 2, level 3 care. And these are our postnatal wards, which are very, very airy, very ventilated. These are our pediatric ICU. And something which has changed our life is these skills lab, where we have all variety of advanced skills lab mannequins, where we train our residents first and then only they touch the patient. So this is about our this thing. Now, I would like to tell you that these are various alternative birthing positions we tried. So before we started, we realized that all these props are very expensive and we need to look into it. So we tried to develop our own ways in low cost, and we have developed this. So one can see that the balls are available. These are the balls which are used in the gyms. And this can be made available, and the rope is the one which has to be tied there. So even though the balls which are available for the birthing, if you get it from outside, they are very, very expensive. Then hydro labor also, we have this special tub which has a system where everything, we have connected it through the vacuum. So the whole blood or anything which comes out, the clots and all, they can be passed out immediately. So there's frequent change of water while she is there. And we have made arrangement that she can sit comfortably during her labor, read books, and or whichever way she wants to. So we have made a resting area there inside the tub. Then we have bars, and then you can see that this is a chair which we have created. We had those armchairs. We just cut it through. So we have made some 5 or 6 such chairs, and we have padded it all over. and beneath is the tray in which cushions are there, and then we make it all sterile by cleaning it and also by putting the sterile sheets over it, and let the women deliver. And the moment she delivers, she puts the baby on her. She only picks up the baby and puts the baby over her abdomen near or in between her breasts. So these have been our observation that when we started doing this, nearly at that time, 850 women were eligible. And among them, 500, they joined dorsal group, whereas the rest of them, they joined different variety of positions. And then when we looked into the second stage, there was significant difference statistically in the length of the second stage of labor, 73.7 versus 37.6. So you can see the p-value was pretty high. When we went into the pain score by using NRS scale, we again realized that there was a very significant difference, and pain score was much, much lesser in the alternative birthing position. Instrumental delivery was, we saw that instrumental delivery was much lesser. It was only 8.6% in the deliveries which we did in alternate birthing position as compared to 12.3% in the dorsal position. Again, episiotomy was performed in 38% of group A patients in dorsal position, whereas it was much lesser. Second degree tear was 16% in dorsal position and 6% in our cases. So we compared different positions again, and for us, the very interesting thing was that in hydro labor, when we did hydro labor, the second stage of labor was significantly reduced and cervical dilatation was fastest during this. So with this study, we came to an end that we are going to do alternate birthing positions, but there were a lot of challenges and we looked into for the solution. So the first thing was that there was no awareness, especially rural women. There was no awareness at all. Even in the doctors and the consultants, there was very little awareness about this. So we started creating awareness by BPCR during antenatal counseling. We have made our own charts. Dr. Sheila and all have come and they have seen all that here. Labor room counseling also has these charts, and there only the moment women come, we show them everything and then they decide whether they want to go or they don't want to go. And we are doing a lot of awareness campaigns in the villages, in our institution. When the women are sitting, we have TV on which we are showing all these positions and doing a lot of awareness. Now, the most important challenge is that do we have availability of the infrastructure and equipments? Do our staff, or would our staff be interested in getting the training for this? And then will we be able to implement? So friends, if we can do it in this rural area, I'm very sure all of you, if you try, you can do it in your area as well. And so we recommend that first have the wish that we have to do respectful maternity care, where a very important component is giving her own right, which is choosing her position. Train your staff and doctors, and the training is very easy. We just went for a week time and we came back and we started doing it. So those areas where these kind of positions, deliveries are going on, we must go there and get trained for a while. We have to do reappropriation of labor room infrastructure, because finally, if you have to put a bar or you have to put a ball, you have to put a, what do you say, hydro labor or chair, you for sure need it to change that whole structure. Please try and get cost-effective props. There's a very special way of FSH monitoring when especially she is in the hydro labor. So one needs to learn that, and one also needs to learn how to support the perineum, in which way that you have minimal tears like first or second degree and not beyond that. And then how do you assist labor? For example, when we do chair labor, we have small stools where we sit down and we look down and we support and deliver the women. And then, of course, we have to generate more evidence to know how how will this alternative birthing positions progress. So I would request that let's all of us use these different birthing positions and make the childbirth moments memorable for her, because that is her right. And so I would say that our motto should be to give respectful maternity care as a universal right to the women, and do these alternate birthing positions and see how do we succeed. Thank you very much for your patience.
Hello, Dr. Manju ma'am, please unmute yourself.
किया था और चला नहीं. Cat. Thank you, Poonam, for your detailed description of alternative birthing positions. But I wanted to see some of the photos of hydro labor.
Ma'am, I wanted to, but then here, you know, they are very particular about the consents and
safety, privacy.
So the privacy, especially in labor, because you're exposing the part, but privately, I can send you all the videos and some pictures. Yeah, this is a forum where I could not really show you the video.
But it was very nice and detailed. And the village ladies, they usually like to deliver in a squatting position. Yes. They sit on the table and try to do that.
So, ma'am,
we have
to
seen
tell you
in
truthfully,
many cases.
to tell you truthfully, last month we have had 106 deliveries with alternate birthing position, where 56 have been chair birth, and chair births are the ones which are being accepted mainly. So everyone is ready to accept chair birth.
Okay. And there are reduction in cesarean rate and instrumental rate. That is the good thing. Very good,
so
very
this,
nice lecture.
Ma'am, this was my thesis for 3 years.
Actually, it was my choice to listen about hydro labor. So I was very much interested in this. चलो तो हमको भेज देना तुम वीडियो एक आध.
We'll send you the videos as well as some pictures.
Thank you very much.
Poonam ji, I have a question. Do you have challenges in monitoring the fetal heart when?
Yes, that's what I was just telling you. That to begin with, we were very uncomfortable with fetal heart monitoring, because you know, every time we would come tell, especially when it was hydro labor, we would tell her to come up, and then we would hear the fetal heart and this thing. But then we got a fetal Doppler, which is one can say that it is a very interesting Doppler in which it is called Sonocade, and you can use it even underwater, and you can hear the fetal heart. So once we got that, after that, hydro labor problem was solved. But for others, it is not a problem, because if you can put this NST machine probe, the heart probe, and you tie it, even if she is roaming here and there, you can hear the fetal heart very easily.
But for stitching the tears, she has to be on her back.
Ma'am, if there is any problem, then of course you have to take her. Like, you can't, it's just the birth. Once she is delivered, once the placenta is out, then of course when you are suturing, you have to put her on the table. That's not possible that in the chair you can do that. Or right? Yeah.
Good.
The challenges are, one, fetal heart monitoring, and second is you know, how to support. One has to really learn how to support. And in lateral position also, ma'am, beautifully baby comes out because you are seeing everything and you are supporting both the area. Rather, it is much better than dorsal position.
And Poonamji, temperature regulation?
You have a thermometer for hydro labor. They have a very special thermometer which you put, and then there's a two-way pipe where from you can get the warm water. So here you have a special geyser which is fixed at one particular temperature. So never very hot water is going to come inside. So you keep measuring the water temperature by that thermometer. And the moment you see that it's going down, then you can just put that switch on and the water, which is warm, comes inside. And she's comfortable. In case...
do you recommend it only for low risk, Dr. Poonam? I mean, high risk women will be more worried.
Yes.
Ma'am, nowadays we were even taking the women who have preeclampsia. And they are delivering so fast. So it has no contraindication of not taking the women in this. Only thing is that one has to be careful as you are careful for all your other patients.
Maybe only mild, no, not severe.
Severe, of course, I mean,
Yeah,
you have to categorize that, you just for the sake of doing alternate birthing position, you're not going to make women prone for anything. So it's just that you have to see what you would like to, or which patients would you like to take. But it's becoming a habit, ma'am, now. And there's one of my sister, in fact, I wanted her to be there today so that she could, but somehow she had COVID and I also had COVID. So I couldn't invite her. So, but I'll share all those things with you.
I think for obese patient, it will be helpful, no? I mean, the better dilatation.
Yes.
Yeah.
Hello.
Obese patient, yes.
Thank you. Thank you.
Atul sir,
Ma'am, I have a question, ma'am.
Yeah, please go ahead.
Ma'am, Poonam ma'am, do you have got training programs for these alternate birthing positions at your place?
So MGIMS has been training for the labor protocols, HDU and ICU training, and emergency obstetric care training. So we do give these kind of training, and our institution is known for these kind of trainings, especially to the doctors, medical officers, and specialists. So if somebody wants to come here, they can come and learn from us. Like we went to Fernandez Hospital, and it was such a lovely experience to meet Dr. Evita Fernandez, and they have a whole wing of midwifery. And as now midwifery has come up, and MGIMS is the nodal center for midwifery training. So we are converting our one labor room completely for midwifery, and all these props are being brought so that we can, start it in an even better way, these alternative birthing positions.
Your maternity wing is very nice.
Very good. Yeah.
Very
neat and clean. Tanushree, are there any questions for the speakers?
There was, if anyone wants to ask any question, our speakers are there. There was one question in the chat box, though Dr. Ganatra had already answered that. Can carbetocin be used after the use of oxytocin as first line? So the answer was yes, it can be. I think Dr. Nidhi or someone put that question in the chat box. Any of our viewers, if you have any question, you are free to ask to our speakers.
Dr. Poonam, I would like to clarify this.
Yes,
it is whatever the champion trial we had,
that is for the prevention.
Prevention. Patients had a little bit of allergic reactions, and in some patients there were bronchospasm. In fact, in patients, I think Dr. Fatima's patient, in two of her patients, they had severe bronchospasm.
Yes.
I think that is what.
Your opinion on that, ma'am?
Side effects, it is mentioned that you have to use it with caution in asthma. Okay.
No, without any history of asthma.
Yeah. I mean, it can cause bronchospasm.
Okay.
Ma'am, actually, ma'am, can I speak? Dr. Anita Rajoria from Delhi.
Yeah,
ma'am, actually the question was that once oxytocin has failed, Can we use carbetocin for the treatment of PPH? I think the carbetocin is using the same receptors as oxytocin. So once the receptors get blocked by oxytocin and it is not effective, they say carbetocin doesn't help much. It is better that you use prostaglandins in those cases in which oxytocin has failed primarily. So prophylaxis, as you have already highlighted, it is very good for prophylaxis, but I'm not sure about its use after oxytocin infusion has been done and it has failed. So what are your comments, ma'am, regarding that?
See, actually, even though it acts better, I mean, what is the thing is that if we have used already, the point well taken, Dr. Anita, that the receptors are already desensitized. So definitely, I mean, we don't know whether even carbetocin will work. But the advantage is we have to use oxytocin, whether we have used it for augmentation or for induction, right? And the advantage of carbetocin will be that the half-life is more. Definitely, it will act better to contract the uterus because the half-life of oxytocin is definitely not like carbetocin. So if we give carbetocin, the half-life is 10 times more than the oxytocin. So definitely it will work. Even though we have used oxytocin, that's what I think. Dr. Poonam can throw more light. I think Dr. Atul wants to say something.
Yeah, so basically, since there is a BCGI approval, and if you look at the WHO guidelines, if you look at ACOG guidelines, all of them are talking about use of carbetocin. The heat stable carbetocin is why, again, what Dr. Poonam said, and I think we've been using it for about 6 months. Let's be very, very clear, first of all, that it is not meant for induction or augmentation of labor. To be very blunt, it is to be used after the baby comes out. We have been giving it only in the first 2 or 3 cases. We used it as a bolus infusion in 100 ml saline. But now we've had an experience of about 106 patients in which we have used as a bolus dose. And by God's grace, as of now, we've not had any problem. And it can be used in the third stage of active management of the third stage of labor. And post-delivery or in the third stage of labor, our use of oxytocin has almost become negligible.
Dr. Atul sir, I'll just like to ask you one question. At times, sir, during C-section, a little part of the placenta is adherent somewhere, not whole of the placenta, and the myometrium at that area gets very thinned out. So even after the uterus is contracted, that one part creates problem. What will be your opinion in managing such type of patient? What type of sutures will you advise, sir?
See, now, first of all, as a routine, whenever I'm doing a delivery or particularly a cesarean, I have a flask with hot water ready. So the minute the patient delivers, the baby placenta comes out, we have that hot mop placed on the uterus. That is the first step. The second step is giving carbetocin now. And then if I feel, I mean, I had a few videos which I could have shown, but because of want of time, I did not elaborate on all the videos because it would have taken a lot of time. If you can indent your finger into the uterine musculature, I would not close that uterus and close the abdomen. I will wait. I will put the uterus inside because the warmth of the abdomen also makes a little difference. But if there is a visible indentation of the uterus, or if I can squeeze the uterus, it doesn't become rock hard. If I can't see serrations on the fundus of the uterus, I will liberally use the Beeline suture because this is your best opportunity. And I have at least 9 patients on whom I have taken a Beeline over the last 3 years have conceived because the fear is whether the patient will conceive again. And most of the patients that I deliver at Fortis and at my hospital are high-risk patients. They are either IVF with twins, which overdistension of the uterus, diabetics, hypertensive, eclampsia, COVID. And I'm a little liberal in taking the Beeline suture because now I am convinced that it doesn't cause infertility. If I feel there is an area on the anterior surface of the uterus which I can indent my finger, I am a little wary of closing that abdomen. I may use misoprostol, I may wait hot water mop, carbetocin, maybe misoprostol sublingual or into the uterine cavity. And if nothing works, I'm not going to wait. And I don't believe in that 20-20-20. I don't think you have 60 minutes. You will exsanguinate the patient if you wait for 60 minutes. I think 5 minutes, 5 minutes, 5 minutes. आप एक काम करिए, एब्डोमेन खोल के 5 मिनट रुक के देखिए कितना टाइम लगता है. I think Dr. Sheila Kumar.
Add something, yeah.
Yes.
As you, I mean, we are talking about Cho suture also. In fact, it is the Cho suture which was the first compression suture.
Absolutely.
In my experience, if I find that very beautifully explained by Dr. Atul, that if you can indent, you know, in that particular area, I have taken the Cho suture, you know. I mean, because, you know, that area which is bleeding, you know, and sometimes we find that that area, suppose if there is adherent placenta, which is near your incision, you know, and it is the upper part, even we can remove that much of chunk, you know, if it keeps on bleeding. And then we can also approximate. In triple P procedure also, it is the lower part which is recommended, you know, because, but you'll have to select the case. But, you know, it is not that Cho suture means always you have to take that 4. Even you can take 2 also. You can select the area which is really bleeding and we can take a Cho suture. Now, Cho suture for lower segment is cervicoischemic, which is transfer. In anterior, I mean the upper segment, which is that square one. But you need a 10 centimeter long needle as it is upper segment. Because the myometrium is thick and your regular needle may not go through and through. So you will need a 10 centimeter needle which goes through and then you come out through and through.
दर्जी का needle लगेगा. दर्जी
I agree
vertical
with
needle.
you. Yeah, vertical.
Needle.
Straight.
You need a straight needle and you'll have to go in and out and come.
Absolutely.
Thank you, sir. And may I now request Mr. Parag from the Blisson Pharma? I think he just want to present a few things about the product Carbecin. Mr. Parag, if you are there.
Yes, ma'am. So first of all, thank you very much to all the organizers for giving us the opportunity to be associated with you. And on behalf of Blisson, I would like to request all of you that Carbecin is available as the first brand of carbetocin in India. And we have already got patented product, which is heat stable also. Currently, the brand available is we are recommending it to store between 2 to 8 degrees centigrade, where we found that the efficacy is much better as compared to the heat stable, because heat stable is to be stored below 30 degrees. And very soon we will be launching with our brand Carbecin HS also, in case some of you wants the heat stable Carbecin, then we have Carbecin HS also is coming. So soon we will be launching it. And our carbetocin is the lowest costing brand available in India. That is at 350 rupees. And we are assuring you that the cost of Carbecin will never cross rupees 400. So that is assurance from our side, and that is we have also assured to government also. So requesting all of you to definitely do try Carbecin. In Uttar Pradesh, we have Surendranath Mishra ji, who will be in touch with you for Carbecin, and he will be assisted by our team over there. So in UP also, Carbecin is freely available now. So requesting all of you, and thank you again for giving us the opportunity.
Thank you. Thank you. In the end, I think we can end the session now.
Yeah,
I really thank all my esteemed speakers and my respected chairpersons to spare their time on this holiday to be with us for such an interesting and educative webinar. And I'll also like to thank Dr. Fatima Shiba. She has been a great help throughout. Otherwise, I wouldn't have been able to bring this excellent webinar to you. I think with these words, I think we can end this session. Thank you so much once again. Thank you, everyone.
Thank you, everyone.
Thank you so much.
Thank you, Atul sir. Thank you, Sheila ma'am. Thank you, everyone.
And thank you, Dr. Preeti, for guiding us in this excellent webinar.
Thank you, ma'am. Thank you, Manju ma'am.
Please stay safe. ध्यान रखिए, मास्क पहन के रखिए.
जी सर.
जी सर.
जी सर.
Thank you, sir.
Thank you, sir.
everybody.
Thank you.
Thank you.